My name's Jonathan, and today we are doing our barium enema trigger. So, I'm the tech who's going to be working with the patient, administering the barium enema. So the first thing that I want to do is to make sure that the room is all set up before the patient comes in. So I have the table prepped. I have the chuck here on the table to absorb moisture in case anything leaks or there are any accidents. That's taped down, so it's not going to move around as the patient moves around. I have my barium set up. This is the kind of barium that we used. It's a 75 to 95% weight per volume, and it's heated to 85 to 90 degrees, a little bit cooler than body temperature. If it's too hot or too cold, it can cause cramping or damage to the colon. So we wanted it just kind of the right temperature, about room temperature. We filled the bag up to about 1,500 cc's, maybe a little bit more, maybe more like 16 or 17, just to make sure that we have enough. The bag is only 24 inches above where I have estimated the patient's anus is going to be, because we don't want it to be too high. Because if it's too high, then the barium be going too quickly. And
do you want to start all over real quick?
No, let's just keep going.
Okay.
We don't want the bag to be too high because that can cause the barium to go in too quickly, and that can be extremely uncomfortable for the patient, as well as it can cause potential damage to the anatomy. So we have the barium all prepped and ready to go. It is clamped off so that it doesn't flow out of the tube until we're ready. I kept the plastic around the tip so that I know that the tip is still sterile. Even while the tip is in there, I'm just going to practice one time to make sure that I can inflate the balloon and let it deflate. I have my hemostat ready for when the exam is actually going on. We'll want to leave the balloon deflated, or inflated rather, inside the patient. I have lubrication to put on the tip to make it go in more easily. I have wash rags at the ready, and I have a stash of towels and things here to use as needed. So, I'm ready to go get my patient. All right. Jose?
Hello.
Hi there, my name's Jonathan. So we're going to be doing an exam today. What brings you in?
Well, they tried to do a colonoscopy, but it didn't work out.
Okay.
And then after tuberculosis,
Okay.
and there's some hemorrhoids in there, and it's just a bunch of stuff.
Okay. All right. All right. Before we go any further, can you tell me your last name, Jose?
No.
All right. When's your birthday?
October 18, 1986.
Okay. I can verify that with my order to make sure everything is correct, and everything is. Assuming everything is correct, we're good to go. So Jose, how long have you been having issues with everything on there?
It's been a few months. I would say
Okay.
like 3 months.
Okay. All right. Have you ever had any surgeries in your abdominal area?
No.
Okay. You have your appendicitis and your gallbladder still?
I'm still in there.
Okay. Still in there. All right. Any chance you may be pregnant?
No, no. I'm pretty
Okay.
sure. No.
Okay. All right. Good deal. Okay. And have any history of cancer for yourself? Okay. All right. So this exam, the purpose of this exam is to look at the large bowel and to just kind of get a better idea of what's going on in there. It sounds like already there's some questions about what may be going on after the colonoscopy, so we're just going to see if we can get some better pictures of what's happening. So I'm going to go ahead and give you a gown to put on. It'll be cover the front side, it'll be open in the back, you can tie it at the neck. You can go ahead and change in the restroom right over here.
Take off my pants and all that.
Yes, I'll need you to remove the pants. By the way, how was your night last night?
It was not good. I was just up all night, just using the restroom every 30 minutes.
Okay.
Yeah.
Alright. So you feel kind of cleaned out?
Oh yeah.
Okay. Alright. It's a kind of miserable night, but it's good to be cleaned out for this exam. So yeah, go ahead and change, and I'll be ready for you when you're out, when you're ready to come out. Alright, April is my assistant. She has just handed me a 14 by 17 film, which I will put in the bucket while I'm waiting for Jose. Alright, and I'm just going to put my marker down on here on the right side, so that is all ready to go. I need to get better sticky on my marker here. I'm ready. Alright. Alright, so go ahead and take a seat up here. Excellent. You can lie down with your head on the pillow.
Okay.
So, the way way the exam works is similar to a colonoscopy in that we're going to be sticking something basically up in the rectum. We're going in through the outdoor, so it's just going to feel weird. It's not going to be really comfortable. What's going to happen is we're going to put this tip inside of you, and then we're going to we're going to administer some barium and try to get it inside to your colon, and then take pictures of it so we can kind of see where it's going in there. Once the tip is inside, we're going to put a little bit of air in the balloon here to kind of help it anchor it in there. I'm not going to do that part. The doctor's going to do that part. I'm just going to put it in for him. But before we put any of the barium inside, we're just going to take a look. One picture here real quick called our scout to kind of see how everything's looking from the get-go. So 14 by 17, I've centered at his crest. I'm going to take this picture with a technique at about 85 or 80 kbp at 32. So I can shield the gonads because Jose is a male, and I can also shield the thyroid, and that's about all I can shield for these pictures, so I'm just going to do that much. So 80 at 32, Jose taking a breath, breathe out, beep. Alright, so we've got the scout there. I'll take my marker and hand this to April.
I'll go run this for you.
Thank you, April. Alright. So what I'm going to want to do is make sure before the exam begins with the radiologist that I have the butt key out of the way so that it doesn't interfere with the fluoro. And before I get the radiologist, I'm going to need to tip Jose. So Jose, I'm going to take this for a moment. Can I have you roll over onto your left side? And your left knee is going to come over the top, left foot comes down. There we go. All right, very good. So, thank you. We're going to glove up. Thank you, April. We want to make sure that we keep Jose covered. So it's already kind of an uncomfortable experience. We want to make sure that Jose is as comfortable as possible. So I'm going to move all of my stuff over to the caudal end of the table. I almost showed Jose the barium bag before we began, and then I thought better of it. He might have seen it anyway. But it doesn't, we're probably not even going to put all the contrast in him. We're just ready in case we need to. So there's no need for him to be freaked out about that. So I test once again to make sure that the balloon is working so I know that when it's in there we can use it. And I put a lot of lube on the tip. Lots of lube to make that go in as easy as possible. Alright. Alright, Jose, we're going to put the tip into the rectum now, okay? So here we go. Alright, Jose, take in a deep breath. Breathe out. Alright, here we go. We're just going to gently breathe as easily as you can. And I'm going to gently slide the tip in, working it slowly in. Thank you, April. I have tape so I can tape it to his leg to ensure that it's kind of anchored, it's not going to move around too much. Alright, there we go. So the tip is in, the tape is holding it in place for now. April, could you go ahead and grab the radiologist?
Yes, I will.
Alright.
Doctor's here.
Alright, so the doctor is here. The doctor inflates the cuff. The doctor does the whole procedure involving the single contrast, the double contrast with the air. The doctor does his thing with the fluoro. When the doctor is done, the doctor leaves. The tip is still inside Jose, and it still needs to stay there while I take my overheads. So, what I'm going to do first off, if we've got a film, perfect. Thank you, April. I'm just going to go ahead and take my LAO first. So, Jose, I'm going to have you roll towards your stomach, but not quite all the way onto your stomach. Your left knee will still be there. Good. Right arm, left arm rather, comes back behind you. Your left knee is on the table there. How are you doing?
Okay.
Okay. All right. So, really it's just a variation of the KUB. I'll edit this out. How do I move the table towards me? Oh, it's the maximum towards me?
Yeah,
Okay.
no.
No, you're good. I'm
Just
just
have
gonna
to
do it
scoot
this
back.
way. I'm just gonna go like this. Okay. So Jose's a little bit too far away from me, so I'm just gonna move him towards me. There we go. Alright. I center at the crest again. Can I have you roll this hip a little bit more forward? Good. I'm centered at the crest. Since we have barium in him now, I'm going to bump up the KBB P to probably about 95. Alright. Jose, take in a deep breath and breathe easy for a moment. I'm going to put my marker down there. And I'm going to leave it there. Take in a deep breath now. Exhale. Hold it out. Beep. Alright. Go. Thank you, April. Alright.
Here you go.
So we've got another 14 by 17. We're going to do a PAKUV. So I'll go ahead and put my marker on there. Alright, Jose, this time can I have you roll onto your stomach? And making sure everything is not getting tangled up over here. There we go. So, once again, 14 by 17 film, 95 at 32, centered at the crest. Jose, take in a deep breath. Exhale, hold it out. Beep. Alright, so that's our PA. Next, we're going to take our PA axial. So this one's going to be on a 10 by 12 cassette. You don't need to expose a whole lot of the body here. We're just looking at the sigmoid colon. So I'm going to angle 40 degrees caudad, going it down 10 by 12, centering at the as-is instead of the crest. So I look for the as-is, I find them there. Alright, we are good to go. I've got my marker on my film. Jose still has the thyroid shield on. Jose, take in a deep breath, let it out, hold it out, beep. Alright, that's our PA axial. So now we're ready for another 14 by 17. Alright. This time we're going to get our RAO. So I want to make sure that the bucky and the tube are lined up. Come back to 14 by 17. My marker is on the film, and I'm centering once again at the crest. Still 95 at 32. Alright, Jose, deep breath in, let it all out. Oh, sorry. Breathe. We want to have them in the RAO position if we're going to take an RAO picture. So good. Bend this left knee towards me. Good. Alright. So yeah, we're diagonal. We're about 35 to 45 degrees angled up. Still centered at the crest. And we're about 2 inches off the mid-sagittal plane toward the elevated side. Alright, Jose, take in a deep breath. Breathe it out. Beep. Alright. Just got a couple more pictures. How are you doing, Jose?
I'm doing good.
Okay. Alright. Thank you, April. Alright, so we're going to do another 14 by 17 film. Thank you. This time, the right lateral. So the right is down. Actually, can I get a 10 by 12? Lateral rectum here. Thank you, thank you. And because it's the right lateral, I'll be using my right marker. So I cone down 10 by 12. And Jose, can I have you roll all the way up onto your side?
Like that?
Yeah, just like that. Perfect. All right. So this time I'm centering once again at the level of his ases and at the mid-coronal plane. I might go up to maybe 100 at 32 for this shot. All right, Jose, taking a deep breath. Let it all out and hold it out. Beep. All right. So that's our lateral. That one is for the rectum. All right, we are ready for another 14 by 17. Thank you, April. We're going to take our 2D cubes. First we'll take the right because the right side is down. These are to look at where the barium is. We're most interested in the air side of the colon in these pictures. So we're going for about 40-inch SID here. Centering once again at the iliac crest. The pad that Jose is lying on is radiolucent, so that provides him a little bit of elevation from the table. I'll take my right marker since it's the right D cube. And I might mark anatomically actually. I would take the left marker and put it on top. So here we go. Jose, take in a deep breath. Let it all out. Hold it out. Beep. All right. And we are ready for excellent. For another cassette, we're using a grid cap, so we're keeping the same technique as we have for our other KUVs with contrast, about 90 at 32. So April has switched out the cassettes. Jose, can I have you scoot a little bit towards me? Then roll onto your back, and then all the way over to your left side. There you go, you're doing good. Keep on coming. Excellent. And take something else here to kind of cover him up once again. How are you feeling? Good. Okay. All right. So once again, for the left lateral, same deal. 90 at 90 at 32. Centered at the crest. I'll use my right marker and put it on top next to his right side. Jose, taking a deep breath. Let it all out. Hold it out. Beep. And breathe. All right. I think I've been forgetting to tell Jose to breathe periodically. Thankfully, he has continued to breathe throughout the exam. So I have taken all of my overheads, since the first one that I took was my LAO. And April is grabbing that cassette to go run it. All right. So we're ready to remove the tip. So Jose, I'm going to take the tip out now, all right? I'm going to deflate the balloon first, because otherwise it's not going to come out. So I deflate the balloon, and I remove it very, very, very slowly, very carefully. His rectum has already been through quite a lot, so we want to make sure we don't add any extra strain to it. So, right, still doing okay? All right, you can go ahead and sit up. So we want to make sure that's all right with you. There we go. How are you feeling now?
I can use the restroom really
You
bad.
too? Okay. All right. All right. Here's what we're gonna do. I want you to hold this, kind of in the front, and if you would like, you can kind of dip it under like a diaper and hold it in the back as well. All right. You doing all right? Here's the step stool here. You can come on down. All right. And we can just head over to the restroom. All right. Take as much time as you need. When you're ready, go ahead and come on out.
I'm ready.
All right. A lot of fun, huh?
Well, yeah. It wasn't as bad as a colonoscopy.
Okay. All right. All right. I've had both of those procedures before, and neither of them was a blast, but you did great.
You did great too.
Well, thank you. So the main thing that you need to remember today is to drink a lot of water. because the barium can kind of dry out. If you don't have enough water, it can make you get constipated. So drink a lot of water. Your stool is probably going to be white or grayish color for the next couple of days. Completely normal, nothing to worry about. Do you have any questions?
No.
Okay, if anything seems wonky or weird, give us a call or give your doctor a call. And you know how to get out of here?
Yes, I do.
All right. Thanks again, Jose. All right, thank you. That's that. All right, so Jose has headed out on his way, and I have shaved. And if the doctor had asked me ahead of time before I let Jose go to take a post-evac film, then I would have taken one more KUB before Jose left after the time that he had gone to the restroom. The post-evac film is especially helpful to make sure that no damage has happened due to the enema tip and the balloon and so forth. The doctor did not ask for a post-evac film in this situation, so I let Jose go simply straight away after using the restroom. So I have pulled up a couple of pictures that we're going to talk about here. These are the ones that I took during the exam, theoretically. Some of these are kind of small and the detail isn't great, but it's enough at least to get the general idea. So here we go. So the first picture that we took with Jose was before any contrast was administered, and that was the Scout, which is a KUB. The central ray is centered at the iliac crest and at the mid-sagittal plane, so it's at the crosshair right in between there. Marker is placed at the lower right-hand corner in this case, and the criteria for this image is that there be no rotation. So we can look at the spine to kind of help us decide. We can see here that we have the transverse processes equal in length on each side of the bodies. So that is a helpful hint there. We can also look down here at the pubic symphysis, and both obturator foramen seem to be about the same proportion and shape and size. And the purpose of the Scout, one of the primary purposes of the Scout image is to make sure that there is no contrast already in the abdomen. If the person had had an upper GI recently or some other contrast study, then there could be contrast in the colon or the small bowel somewhere that would interfere with the barium enema and the diagnostic purposes of it. So this person looks pretty okay. Jose looks pretty good. He checked out here. So this one would probably be shot at about 80 to 85 kVp and 25 to 30 mass. We don't need to have a really high technique for this one because there's no contrast yet. From here, the next picture that we took was the LAO. And the LAO should show the entire colon in the one shot. The left colic flexure, right up here, the splenic flexure it's also called, is the one that is opened up in this projection. So this is the one that we want to see really well. The right colic flexure is going to be a little bit closed off here. The left is open. We can see there's a lot of barium up in here. The patient is rotated 35 to 45 degrees, and the CR, the central ray, is the crosshairs are placed at the level of the iliac crest and 1 to 2 inches lateral to the mid-sagittal plane toward the elevated crest. We bump up our KVP on this one to about 95 at 30, or 95 maybe at 25. In any case, we need to have a higher KVP to help penetrate the abdomen now that we have contrast in there. The PA was the next picture that we took. So obviously, there's not as much barium in this picture. Unfortunately, I think these are all not Jose. So anyway, it is what it is. The PA also needs to show the entire colon. It needs to show both flexures and the rectum. This one is probably not ideal because it's cutting off some of the rectum there. It may not need to be repeated, however, because we are going to take a lateral rectum shot and there will be a number of other pictures, overheads, that we have the opportunity to get the rectum in as well. This is just like a KUB. The central ray is centered at the iliac crest and at the mid-sagittal plane. Same technique for this one as the previous one, 95 at 30 or 95 at 25, just about. So far, I haven't seen any blaring abnormalities in the colon. What we might see would be diverticula, which maybe in the next picture, at least it's a little bit bigger. If we saw a lot of pouches hanging off of the colon, that could be an indication of diverticulosis or diverticulitis. Also, what would appear particularly to a radiologist's eyes might be the presence of polyps, which would be growths on the colon that protrude into the wall, like little chocolate chips kind of lining the wall, I guess. Maybe that's not the best way to describe it, but in any case, so far no crazy abnormalities seen in these pictures taken here. This is the PA axial projection, and in this projection we really want to see the rectal sigmoid area, and with less superimposition than we had up here in the PA. Everything's a little bit closed off there, and even in the LAO. But here in the PA axial, we've kind of opened up the sigmoid colon a bit so we can visualize it better to see if there is any pathology there. The tube angle, since the patient is prone, is 40 degrees caudad. It's at the mid-sagittal plane and the level of the as-is. So it's a little bit lower than the previous ones, a little bit lower than a KUB at the as-is instead of at the iliac crest. We now move on to the RAO position. So with this one, pardon me, we want to see again the entire colon. It looks like we have the left colic flexure cut off a little bit here, but in any case we can see that the right colic flexure, the hepatic flexure, has been opened up a bit by this projection, and that's what we really take this projection for, the right colic flexure. Again, we want the central ray to be perpendicular. The patient is rotated 35 to 45 degrees, and the central ray enters at the level of the iliac crest, and 1 to 2 inches lateral to the mid-sagittal plane. It's going lateral toward the elevated side, the elevated iliac crest. So this shot is for the hepatic flexure. Here we go. Lateral rectum is the next one that we took. And the important thing about this image is that we want to make sure there's no rotation. So we can look and see that the femoral heads and the acetabula are not rotated, they are superimposed. We can also see a lateral sacrum in here, and we can see the tip of the tube and the balloon, and then all of the contrast coming up into the rectum. So again, we see the rectosigmoid colon here, we're getting the sigmoid here, but especially the rectum. And so this is an important shot because of things like up here and in other pictures where we lost the rectum. Because the film was aimed a little bit too low, or we were looking at something up higher. So we want to make sure that we can see the rectum, so we have a specific shot just for it. The central ray is perpendicular on this one. It enters at the level of the as-is, so the anterior superior iliac spine, and the mid-coronal plane. So, and we want the sacrum and coccyx to be included in here for a point of reference. To kind of see exactly how everything is going with the anatomy in here. Next we have our right decubitus, our right lateral decubitus film. Again, with this one we want to make sure there is no rotation. So it's difficult to see in this particular image, but sometimes we can look at the hips and the pelvis to make sure. Sometimes the spine also is helpful to let us know that nothing is rotated. We just want to be looking at everything straight on. These two shots, the decubitus shots, are the money shots. They give us the most information. What we're looking at is the free air. The barium drops down there. That's very opaque, so we don't see a whole lot of that, but there's a whole lot that we can tell from these areas in here that have kind of the walls that are dripping the barium down. It's a great way for any abnormalities such as diverticulosis or polyps to be displayed. The central ray for this shot is horizontal because we're shooting towards the table, and it's perpendicular to the imaging plate. It is centered at the iliac crests and the mid-sagittal plane, once again, just like a regular KUB would be. We're looking in this picture, since this is a right lateral decube, we are looking at the medial ascending colon and the lateral descending colon. So we're looking up here at the descending colon, the lateral side, and we're looking here at the medial ascending colon. The last picture that we took was the left lateral decubitus. So here the barium is all on the left side this time. It has come down here, and we are looking up at the air-filled parts of the colon. So in this case, we are looking at the medial descending colon, so the medial side of the descending colon, and the lateral side of the ascending colon right here. And this particular shot seems to be showing some sort of abnormality in there. And I am not a doctor, but that doesn't look good. That could be any number of things, really. I can't tell exactly from this angle whether those are growths that are popping into the colon or that are pressing outward. They could be polyps. I'm not sure exactly what they are, but this doesn't look super good. I would never say any of that to a patient, of course, but this particular picture up here, our right lateral decubitus, didn't seem to show anything too suspicious, and this one, which is theoretically the same patient for the purposes of the trigger, is showing a few more problematic things. So all of these ones here, the decubitus shots and all of the other KUBs with rotation or whatever it is, would be shot at least 90 kVp. We want to make sure that we penetrate the parts of the body that have the contrast so that we get a good diagnostic image.